Welcome to the funnel effect.
It is a massive day in cardiology, and we have one of the most important new guidance documents to unpack today.
Absolutely. What we're looking at is really nothing less than a paradigm shift.
For sure, it's about how we manage the intersection of America's two most common chronic diseases, obesity and heart failure.
And for this deep dive, we are unpacking the 2025 ACC scientific statement on the management of obesity in adults with heart failure. This just came from the American College of Cardiology.
And it's not just any document. I mean, you look at the names on the ACC writing committee, it's a who's who.
Right.
Chaired by Michelle M. Kittleson, and you've got Amelia J. Benjamin, Vanessa Bloomer, Josephine Harrington, James L. Januzzi,
Murray.
John J.V. McMurray, Amanda R. Vest. I mean, this is a stellar group. Their collective expertise tells you just how vital this is.
It really does. And the core premise they're tackling is, well, it's something we've known but maybe haven't had the tools to address. Obesity isn't just a comorbidity. It's a massive independent driver of heart failure, not to mention coronary artery disease and stroke. But for so long, clinicians were kind of stuck, right?
They lacked safe and, truly effective interventions for weight loss, especially in these really complex heart failure patients.
And that's exactly why the statement is so timely. We're in the middle of a pharmacological revolution.
Completely.
Yeah.
It's driven by these novel anti-obesity medications, or AOMs. You're talking about semaglutide, tirzepatide,
The GLP-1s.
the GLP-1 and the dual GLP-1 GIP agonists, yeah.
Yeah.
The data from the trials is just so robust now. It's proven that intentional weight loss isn't just possible.
It's powerfully therapeutic.
Exactly. Especially for heart failure with preserved ejection fraction, or HFpEF.
So our mission today is to cut through this really dense, important material and pull out a roadmap, for diagnosis, for risk assessment, for the actual management strategies.
From lifestyle all the way to surgery and these new meds, we need to see how this new evidence base actually applies in the clinic.
And we have to tackle the challenges head on, like the massive limitations of BMI, which we all use every single day.
Right. And the really critical safety issues when you're using these intensive treatments in vulnerable people, especially those with heart failure with reduced ejection fraction, HFrEF.
Okay, so I think there are three big questions we need to answer for you today right out of the gate. First, body mass index, BMI, we've used it forever. Is it still the right tool for diagnosing obesity in a heart failure patient?
And if it's not, what do we use instead? I mean, that's the foundational question, isn't it? The limitations of BMI are they're so stark in these patients, where you have fluid and muscle wasting throwing off the numbers.
Okay, second question. How big of a deal are these new AOMs? Are they really changing outcomes for patients with HFpEF? And if they're that powerful, what are the safety tripwires? What do clinicians absolutely have to be watching for?
And finally, if AOMs are revolutionary, then bariatric surgery, or MBS, is the most profound intervention we have. What's the real benefit for a patient who already has heart failure?
And how do you balance that against the risk? Because the sources cite some really scary post-operative mortality rates.
They do. It's a very fine line to walk.
All right, let's start then with just the sheer scale of this problem. We need to look at the numbers and then unpack that historical controversy, the so-called obesity paradox that really held back treatment for decades.
So looking at the epidemiology in the U.S., the figures are, as you said, alarming. This isn't a small problem.
Not at all.
U.S. prevalence of obesity, and that's a BMI of 30 or higher, was already at 41.9% between 2017 and 2020. I mean, that's staggering in itself.
But the projections, that's where it gets truly terrifying. What are we looking at in the next couple of decades?
The models are projecting that the prevalence of obesity in the U.S. will hit 60.6% by the year 2050.
60%.
60%. Just think about that. We are heading toward a future where nearly 2 out of every 3 adults could be living with obesity, and heart failure is tracking right alongside it.
The burden is just immense.
It is. HF prevalence is expected to jump from about 6.9 million patients today to 11.4 million by 2050. The lifetime risk. It's about 1 in 4 U.S. adults will develop heart failure.
And the overlap is impossible to ignore.
You can't. In the recent NHANES data, 64.2% of people with heart failure also self-reported having obesity. That is the vast majority of the HF population.
So the statement is really cementing this idea that obesity isn't just there. It's a primary mechanistic driver of heart failure. How strong is that link? quantitatively?
It's a very clear dose-response relationship. For every 4-kilometer increase in BMI, there's a 1.2-fold increased risk for developing heart failure.
Okay.
But here's the really key distinction, and it's essential for everything else we're going to talk about. That relationship is significantly stronger for HFpEF heart failure with preserved ejection fraction than it is for HFrEF.
Why is that difference so profound? What is it about obesity that drives the HFpEF phenotype so strongly?
Well, HFpEF is, at its core, a disease of stiffness and dysfunction. And it's often driven by things like systemic inflammation, hypertension, metabolic problems.
All things linked to obesity.
Exactly. Excess fat, especially the visceral fat deep in the abdomen, it's not just sitting there. It acts like an active endocrine organ. It pumps out inflammatory cytokines that stiffen the heart muscle and the blood vessels, and that leads directly to that HFpEF picture.
And this brings us to the population attributable fraction, or PAF. Just to remind everyone, this tells us what percentage of cases could be eliminated if we got rid of a single risk factor, in this case, obesity.
And the PAF data is just crucial for understanding prevention. It shows the difference in impact so clearly. For example, in the U.S., obesity was responsible for 22% of HFpEF cases in white women,
22%.
but only 6.6% of HFpEF cases in that same group. The difference is huge.
And it's even more stark in other populations, isn't it?
Oh, absolutely. In black women in the U.S., the PAF for HFpEF that's attributed to obesity shoots up to 40.4%.
40%.
40%, versus just 4.5% for HFrEF. I mean, that's incredible. It means that targeting obesity in that specific group could potentially prevent 4 out of every 10 cases of HFpEF.
So the statement is basically saying that avoiding excess weight throughout your life is one of the single most important things you can do to prevent this type of heart failure.
It's a primary mandate for prevention, no question.
Beyond just causing the disease, what does obesity do to the daily life of a patient who already has heart failure? What's the symptom burden like?
It's significantly greater. Patients with HF and obesity have more symptoms. They have reduced physical capacity, so more shortness of breath, more fatigue. They have a lower overall quality of life, and critically, they end up in the hospital more often. The disease is simply more severe.
Which brings us to that great controversy, the thing that I think really held clinicians back for decades, the obesity survival paradox.
Right.
The idea that if you already had heart failure, being overweight or even a little obese was better, that it was somehow protective. What is the final word from the ACC on this?
The consensus is definitive and powerful. The paradox is an illusion. It was an artifact of flawed studies, and we have to move past it. It should no longer be a reason to avoid treating obesity in HF patients.
So what were the flaws? What were those older studies missing?
Several things, but the most critical one is something called reverse causation.
Okay, break that down for us.
The underweight patients they used for comparison, they often had that low BMI because of unintentional weight loss. They were already suffering from advanced disease, from muscle-wasting cardiac cachexia.
So they were already sicker. The low weight was a symptom of dying, not a cause of health.
Exactly. Comparing a stable obese patient to a severely ill cachectic patient is what skewed the survival data. The low BMI was just a marker of how sick they were.
And were there other issues?
Yeah, things like incomplete adjustment for other factors, and of course the limitations of using BMI alone. But here's the real scientific breakthrough. The paradox completely disappears when you define obesity by central adiposity, by belly fat, not just by BMI. Once you account for where the fat is, that protective effect vanishes, and the real harm of obesity becomes crystal clear.
So the takeaway is a call to action. We can and should be treating obesity in these patients because intentional weight loss leads to better symptoms, better function, better quality of life, and fewer hospitalizations.
That's the bottom line.
Which brings us directly to our first big question. The diagnosis itself. You know, BMI is everywhere. It's in every EMR. It's easy. It's cheap. If it's so flawed, why is it particularly bad in a heart failure patient?
Its limitations are just magnified because heart failure itself creates all these confounding variables. First, as we know, BMI can't distinguish between fat mass, muscle mass, or, and this is critical in HF, fluid retention.
Right. The patient could be retaining liters of fluid.
Exactly. A patient could be hypervolemic, full of fluid, and that artificially inflates their weight and their BMI. Treating their obesity isn't going to fix their congestion, which is the immediate danger.
And what about the muscle mass issue?
Well, advanced HF patients often suffer from sarcopenia muscle wasting. So you could have a patient with a seemingly normal BMI of, say, 27. But that number could be masking a dangerously high percentage of fat and a very low failing amount of muscle.
So BMI hides this really dangerous body composition.
It does. And as we just said about the paradox, it tells you nothing about where the fat is stored. It treats all fat equally, which we now know is just scientifically wrong.
Okay, so if BMI is out, or at least insufficient, what's the new diagnostic framework that the ACC is pushing for?
They're supporting a conceptual shift that was proposed by the Lancet Diabetes and Endocrinology Commission. It's the distinction between preclinical obesity and clinical obesity.
Let's drill down on that. What's the difference?
Preclinical obesity is basically having excess body fat, but with your organ function still preserved. The body's coping.
Okay.
Clinical obesity, on the other hand, is defined as a chronic disease, where that excess fat has actually caused an alteration in the function of your organs or your whole body.
So if a patient has excess fat and they already have established HFpEF, they automatically have clinical obesity. The organ is already dysfunctional because of the fat.
Correct. The HFpES itself is the proof of organ dysfunction. So the question then becomes, how do we practically confirm excess adiposity in the clinic? Especially for those patients in that tricky zone, maybe a BMI between 25 and 35.
Right, where it could be muscle, it could be fat, it could be fluid.
Exactly. For those folks, the diagnosis needs to be confirmed one of two ways. You can use a direct measurement like a DXA scan, which is the gold standard, but, it's expensive and not always available.
Or the more practical option.
The more practical option is using at least one anthropometric measurement in addition to the BMI. And the ACC statement is really endorsing waist circumference as the most accessible tool.
Because that gets at the central adiposity.
It gets right to the heart of the problem. The thresholds they recommend are 35 inches for women and 40 inches for men.
So the job for the clinician is simple. Grab the tape measure. It moves the diagnosis from one flawed number to a much more accurate picture of their real cardiovascular risk.
It connects the diagnosis directly to the pathophysiology. Simple as that.
Now, the statement makes a really important point about the human factor here, sensitivity and stigma.
And this is so vital for anyone practicing medicine. The statement is very clear. Obesity is a highly stigmatized condition. Clinicians have to be aware that patients can feel real discomfort, even shame, just from being weighed or measured, or even talking about their weight.
It's about framing it not as a moral failing, but as a treatable chronic disease.
100%. It's about collaborative management, not judgment. You have to have a sensitive, objective approach.
Okay, so once we have that diagnosis of clinical obesity, we move into risk assessment. And it seems like obesity makes diagnosing the heart failure itself even harder.
It does. Obese patients are just harder to evaluate. The traditional physical exam, looking for jugular venous distension, checking for edema in the legs, it becomes less reliable because the extra tissue gets in the way.
And even our more advanced tools can fail us.
Yeah, even an echocardiogram can be hampered by poor acoustic windows, which might lead you to underestimate how congested the patient really is.
So if the physical exam and the echo are unreliable, what's the gold standard for diagnosing HFpEF, even if it's invasive?
For a definitive diagnosis, you often need to do a right heart catheterization and measure their hemodynamics, specifically the pulmonary capillary wedge pressure, or PCWP.
Can you explain for the listener what PCWP is and why it's so critical here?
For sure. PCWP is basically a proxy for the pressure inside the left atrium. It tells you how stiff and pressurized the left side of the heart is. In HFpEF, the heart struggles to relax, so pressures might be normal at rest.
But they shoot up under stress.
Exactly. That's why the true gold standard often involves measuring the PCWP during exercise. The criteria are a peak exercise PCWP of 25 mmHg or higher. It's complex, and it just shows how tough this diagnosis can be.
But the trickiest part of all seems to be with our standard blood tests, the natriuretic peptides BNP and NT-proBNP. These are the go-to tests for ruling out heart failure. Why do they fail us in patients with obesity?
This is probably the single biggest diagnostic pitfall that this statement highlights. For a few reasons, obesity actually suppresses the production of BNP and NT-proBNP.
Oh.
The adipose tissue itself seems to increase the clearance of the peptides from the blood, and the fat also seems to blunt the signal for the heart to produce them in the first place, even when it's under stress.
So the patient's heart is stretched and overloaded, but the test comes back looking normal, or at least not very high.
Exactly. You get a falsely reassuring result. The data on this is really sobering. The standard rule-out threshold for NT-proBNP is less than 125.
Right.
But in patients with a BMI over 35, that threshold had only 67% sensitivity.
So for every 3 patients with severe obesity who actually had heart failure, we were missing one of them if we relied on that standard cutoff.
That's right. The error rate is dangerously high, so the consensus is clear. Clinicians have to use lower thresholds and just have a much higher index of suspicion for heart failure in a patient with obesity and symptoms, even if their NP levels look normal.
So once you have the diagnosis, the statement says you need comprehensive comorbidity monitoring. What specific checks should be standard practice?
Well, the conditions all travel together, so the list is pretty long. First, you have to be screening for type 2 diabetes and high cholesterol. That's a given.
Okay.
Second, diligent blood pressure monitoring. Obesity-related hypertension can be sneaky. It often shows up as masked or nocturnal hypertension, which you'll miss in the clinic. So you really need 24-hour ambulatory monitoring to catch it.
And what about things like heart rhythm and breathing?
You have to screen for atrial fibrillation, which is incredibly common. And then there's sleep-disordered breathing, sleep apnea. It's a silent killer, and it's rampant in both obesity and HFpEF. If you're suspicious, that patient needs a sleep study.
Finally, you have to actually measure how they're functioning, not just look at their labs.
Right. That's where objective assessment comes in. Simple things like a 6-minute walk test or checking their grip strength can tell you a lot about their functional reserve. And if you find deficits, that's when you can target interventions like cardiac rehab.
All right, let's move into management. We've established that intentional weight loss is key. The foundation, of course, is always lifestyle. The goal here is modest, right? About 5% to 10% weight loss through diet and exercise.
And that modest goal is really powerful. The statement confirms that even that 5 to 10% loss leads to substantial benefits. We're talking improved risk factors, better functional status, fewer symptoms, especially in HFpEF. It makes patients feel and move better right away.
But the big problem has always been sustainability. And the statement really leans on the Look-Ahead trial to make this point. Can you walk us through those findings?
Look Ahead was a massive landmark trial. Over 5,000 patients with obesity and type 2 diabetes. They put one group on an intensive lifestyle intervention. And at 1 year, the results were great. They lost 8.6% of their body weight versus less than 1% in the control group.
A clear short-term win? But what happened over the long haul?
That's where it gets tough. After nearly a decade, that difference had really shrunk. The intervention group had kept off about 6% of their weight, but the control group was at 3.5%. The gap was closing. It just shows how hard sustained behavioral change is.
So what's the key lesson for clinicians from that?
Well, even though the overall trial didn't show a big cardiovascular benefit, secondary analysis found something really important, a threshold effect.
Meaning
Meaning the people who successfully lost 10% or more of their weight at that 1-year mark, they saw a 21% reduction in cardiovascular events.
so it's not enough to just try. You have to actually hit a certain target for the heart to really benefit in the long run.
Precisely. And that really sets the stage for why we need more powerful tools, like the AOMs we're about to discuss.
Okay, let's break down the components. Exercise. Is it a good strategy for losing weight?
The sources are clear on this. Exercise by itself is generally not an effective way to lose a lot of weight. Calorie restriction is the main driver of weight loss.
But it's still essential.
Oh, absolutely essential for 2 huge reasons. First, it profoundly improves function and quality of life in HFpEF patients. It makes their day-to-day life better. And second, exercise is a powerful predictor of keeping the weight off once you've lost it. It's key for maintenance.
What about specific diets? Is there one magic diet that the ACC recommends?
No, and they're wise not to. They don't endorse any single diet. Adherence is probably more important than the specific type of diet. However, they do note that Mediterranean-style diets with things like olive oil and nuts are consistently linked to better long-term weight maintenance and overall heart health.
So the conclusion here is that lifestyle is the foundation, but we have to be realistic about how hard it is to achieve and sustain the kind of weight loss needed for maximum benefit.
Right. It's necessary, but often not sufficient.
Which brings us to the revolutionary part of this deep dive. The anti-obesity medications, the AOMs. We're in a completely new era.
A completely new era. The old drugs, like fenfluramine, had major safety concerns that made them basically unusable in heart patients. That's all changed.
We're now in the age of these third-generation hormone-based therapies.
And the difference is the mechanism and the magnitude of the effect. We're talking about GLP-1 and dual GLP-1 GIP agonists like semaglutide and tirzepatide. These drugs can lead to 10% to 20% total body weight loss.
Which is squarely in that prognostically beneficial zone we just talked about.
Exactly. And the ACC's recommendations here are built on 2 huge pivotal trial programs. STEP-HFpEF for semaglutide and the SUMMIT trial for tirzepatide.
And who were they studying in these trials?
A very specific, very high-risk population, patients with symptomatic HFpEF and a BMI of 30 or higher.
Okay, let's start with semaglutide and STEP-HFpEF. What did they find in terms of how patients felt and functioned?
The benefits were significant. They used a quality-of-life score called the KCCQ. At 52 weeks, patients on semaglutide had a 7.5-point improvement.
For the listener who isn't a cardiologist, what does a 7.5-point shift on the KCCQ actually mean? What does that feel like?
It's massive.
Yeah.
A 5-point shift is considered clinically important, so 7.5 points is a huge deal. It can be the difference between being severely limited by your symptoms and feeling like you can live a mostly normal life. It's a change patients really feel.
And what about their physical capacity?
That was measured with the 6-minute walk test. Patients on semaglutide could walk, on average, 17.1 meters further. Again, a tangible, measurable improvement in their endurance, which came along with an 8.4% weight loss.
Then came tirzepatide in the SUMMIT trial, which is a dual agonist and aimed for even more weight loss.
It did. Tirzepatide delivered an even greater weight loss, an 11.6% placebo-corrected change, and they followed patients for longer, about 2 years. But crucially, SUMMIT also looked at hard cardiovascular events.
What was the endpoint, and did they hit it?
The co-primary endpoint was a composite of a worsening heart failure event or cardiovascular death. And yes, tirzepatide hit it, showing a significant reduction with a hazard ratio of 0.62.
An HR of 0.62, so a 38% relative risk reduction. That suggests it's improving the disease itself, not just the symptoms.
That's the strong implication. While the number of events was modest, the trend is overwhelmingly positive.
Which brings us back to the mechanism. Is this just about losing weight, or is there something special these drugs are doing to the heart?
The consensus seems to be that it's both. A lot of the benefit comes from the weight loss, but the trials also showed other favorable changes. Biomarkers like NT-proBNP went down, inflammation markers went down.
And what about structural changes to the heart?
This is key. Imaging studies showed a reduction in the mass of the left ventricle, so less stiffness, and, maybe most fascinatingly, a reduction in something called paracrine adipose tissue.
Paracrine fat. What is that, and why is it so important in HFpEF?
Paracrine fat is the fat that's literally surrounding the heart and the major blood vessels. And it's not just sitting there, it's metabolically active. It releases inflammatory signals directly onto heart muscle, which promotes fibrosis and stiffness.
So by reducing that specific fat, the AOMs might be directly treating the root cause of the stiffness in HFpEF.
That's the hypothesis.
Yeah.
They might be acting locally on the heart, a benefit that goes beyond just general weight loss.
Okay, these drugs are clearly powerful, but the ACC statement is adamant that you can't just write a prescription and walk away. There needs to be meticulous, structured monitoring. What does that look like?
It's a multi-phase process. Before you even start, the patient needs to be clinically stable. No recent hospitalizations for HF, no unstable arrhythmias. You need baseline labs for kidney function, electrolytes.
Then comes the tricky part, titrating the dose.
This is critical. You have to go up slowly, usually every 4 weeks, to manage the main side effects, which are gastrointestinal nausea, vomiting, diarrhea.
And those symptoms are the real tripwire, aren't they?
They are, because if a patient has severe nausea and vomiting, they can get volume depleted very quickly. And a volume-depleted HF patient is at high risk for acute kidney injury.
Right.
So the clinician has to be watching their labs closely and be ready to adjust their other medications, their diuretics, their blood pressure pills. You're basically walking a tightrope between volume overload and volume depletion. It requires expert management.
Let's talk about the big evidence gap. HFrEF, patients with a weak heart pump. The big trials were all in HFpEF. What do we know about using these drugs in HFrEF?
We have a critical, undeniable lack of data. These agents have not been studied extensively enough in HFrEF, which is why the ACC statement is very, very cautious.
What's the specific worry with HFrEF? We know they can increase heart rate.
That's the primary concern. In HFrEF, a higher heart rate is generally a bad thing, and older, smaller trials with a different GLP-1 drug, liraglutide, actually raised some red flags in HFrEF patients' potential signals for more hospitalizations and arrhythmias.
So if there's a prior signal for harm, why isn't the recommendation just a flat don't use them? Why the cautious language?
It's a real clinical dilemma. The caution reflects the immense potential benefit we see in HFpEF, balanced against the known physiological risk in HFrEF. So the consensus right now is that using these drugs in HFrEF is off-label and should be done with extreme caution, probably only after other options have failed, and only until we get dedicated safety trials.
Which are badly needed. Okay, let's move to the final management strategy, metabolic and bariatric surgery, or MBS. If AOMs are effective, MBS is the most powerful weight loss tool we have. How effective is it?
It offers the most profound and sustained weight loss, period. A Roux-en-Y gastric bypass can lead to an average of 31% total body weight loss at 1 year, and that often stays off for a decade or more. A sleeve gastrectomy is around 23%. The magnitude is just unparalleled.
Okay, so given the benefits we're seeing with AOMs, are there big randomized trials showing that MBS helps patients who already have heart failure?
And that's the crucial point. No, there are no randomized trials of MBS in patients with established HF. All the data we have comes from observational studies.
And what does that observational data suggest?
It's compelling. In people without HF, MBS is linked to a nearly 50% lower risk of developing heart failure down the road. And in patients who already have HF, it's associated with a lower risk of hospitalization and death from heart failure. The benefit seems to be real.
That sounds like a very strong case for surgery. But now we have to talk about the huge caveat, the major warning in the statement.
This is the critical warning, and it needs to be stressed. Patients with established heart failure who undergo MBS face a significantly increased risk of postoperative complications and death. The risk profile is extraordinarily high.
How high? The sources cite specific numbers for inpatient death rates.
The rates are substantially higher for HF patients compared to non-HF patients getting the same surgery. The risk of inpatient death was threefold higher for HFrEF patients and 1.5-fold higher for HFpEF patients.
A threefold higher risk for HFrEF patients. That is extreme. What are the specific complications they're running into right after surgery?
Things like heart attacks, pulmonary edema, atrial fibrillation, acute kidney injury, sepsis. The enormous physiological stress of major surgery on an already compromised heart just pushes these patients over the edge.
So what's the bottom line? Does the ACC say avoid MBS in HF patients altogether?
No, but the conclusion is very restrictive. It's not ruled out, but it requires extreme caution. It's only for carefully selected patients who have been maximally optimized on their HF medications first, and it must be done in a specialized center with a multidisciplinary team that's expert in both HF and high-risk surgery.
What about patients with advanced HF, the ones on LVEs or left ventricular assist devices?
Obesity is a major problem for them too. It's linked to higher rates of device thrombosis and infections. And historically, a high BMI was a major barrier to getting on the heart transplant list.
So MBS is sometimes used as a bridge to transplant for these patients.
Exactly. It's a tool to get their risk profile down enough to even be considered for transplants. But again, these are exceedingly complex procedures that can only be done in the most specialized centers.
Okay, let's look to the future. We've established weight loss as a core goal, but we've hit some big evidence gaps. The first one seems to be which strategy is best: lifestyle, AOMs, or surgery?
And the simple answer is we don't know. We don't have the head-to-head randomized trials. We can't say for sure if losing 15% of your weight with tirzepatide gives you a better long-term prognosis than losing 15% with a sleeve gastrectomy. That research is vital.
And this brings us to a really serious emerging concern with the current AOMs, the risk of sarcopenic obesity.
This is a critical safety issue, especially for older, frail HFpEF patients. Sarcopenic obesity is that dangerous mix of low muscle mass and high body fat. It's a huge predictor of poor outcomes.
And the AOM trial showed that a significant portion of the weight loss wasn't fat, right?
Right. The source notes that in some of the big trials, up to a third of the weight lost was lean mass muscle. And while losing fat is great, losing functional muscle in an older HF patient is highly detrimental. It can make them weaker and less able to recover from an illness.
So what's the recommendation to counter that?
The future has to be about synergistic treatment. We have to combine the AOMs with things like resistance exercise and specific nutritional support that are explicitly designed to preserve or even build muscle mass while the fat is being lost.
Looking at the drug pipeline, if dual agonists like tirzepatide are better than single agonists, does that mean even more potent drugs are coming?
Absolutely. That's the central hypothesis driving the next wave of research, that more weight loss will lead to even greater benefit.
So what's next?
We're already seeing the rise of triple agonists. The statement highlights a drug called retatrutide, which is a GLP-1 GIP-GCG agonist. It's ultra potent. It's being studied right now.
And are any of these new agents designed to solve that sarcopenia problem we just talked about, to spare the muscle?
Yes, thankfully.
Yeah.
The statement mentions one called HU6. It's being studied in the Humane HFpEF trial with the specific goal of reducing fat mass while actively sparing skeletal muscle. If that works, it would be a true game changer.
This whole shift suggests that the old cardiology clinic model isn't really enough anymore. The statement talks about the need for specialized cardiometabolic clinics. What does that look like?
It's essential because all these conditions, obesity, diabetes, kidney disease, they're all linked, and they all drive heart failure. It's too much for one cardiologist to manage alone.
So it's a team approach.
Exactly. You integrate cardiology, endocrinology, nutrition, behavioral therapy. You have specialized pharmacists helping manage these complex drugs. It's a holistic approach to optimize all the metabolic risk factors at once.
Finally, the statement raises a huge societal concern: equity. These new AOMs are expensive. What's the risk of making health disparities even worse?
The statement calls this out as a top priority. We know that obesity is more common in communities facing adverse social drivers of health. If these life-changing drugs are only accessible to the wealthy, we risk creating a two-tiered system of care and making health inequities even worse.
So ensuring equitable access through policy changes is critical.
It's an absolute necessity.
Okay, to wrap up this deep dive, it's clear that managing obesity is now a central, mandatory part of heart failure care, especially for HFpEF. And we can finally put the obesity paradox to rest.
Second, our diagnosis has to evolve. BMI isn't enough. We need to use central adiposity measures like waist circumference, and we need to approach these conversations with sensitivity.
Third, the new AOMs offer powerful benefits in HFpEF, but they demand meticulous safety monitoring, and they remain largely unproven in HFrEF.
And fourth, while bariatric surgery offers the most weight loss, it has to be reserved for only the most carefully selected patients because of those significantly increased post-operative risks.
Before we close, here's one final provocative thought for you to consider. Given the rapid emergence of increasingly potent weight loss therapies and this recognized challenge of losing muscle mass sarcopenia, how should clinicians balance the immense therapeutic potential of these drugs against the unknown long-term risks, particularly when it comes to maintaining a patient's functional capacity if they have to stop the medication years down the line?
That question of long-term maintenance, especially off treatment, and the preservation of muscle function, that is truly going to define the next decade of cardiometabolic care.
Thank you for watching The Funnel Effect.